I must give you a disclaimer that I am a laboratorian by profession, being a chemical pathologist. I know there are many clinicians on tonight's webinar, including gynecologists, and by no means do I profess to be an expert in gynecology. And so I'm giving you tonight more a lab perspective on managing your patients with PCOS and menopause. You know, there's so many jokes and memes around the topic of menopause. I mean, if we look at the first one, when I asked for a smoking hot body, menopause was not quite what I had in mind. And that is referring to the hot flushes that women experience. The other common joke or meme is menstruation, menopause, mental breakdowns. Notice how all of women's problems begin with men. The other jokes or memes about brain fog, that awkward moment when you're not sure if you actually have free time or if you're just forgetting everything. You know, the way brain fog that women experience during this time. The insomnia, no, I haven't slept well. Why do you ask? The other one is the grouchiness and the mood swings that women experience and that are often joked about. That is menopause in progress, go around and do not make eye contact. Here we have a squirrel that's terribly anxious, and that's the anxiety associated with menopause. To chill out, people, I'm handling it. And here we have Carol, who found her own way of coping with the hot flushes. So recently, you know, menopause has been demystified in pop culture by the likes of Oprah, who has introduced to her studio Maria Shriver, Naomi Watts, and celebrities to discuss this taboo topic of the menopause revolution. And this has really opened up the topic about what women experience and the fact that many women are going to spend 2/3 of their life in this phase where they're still expected to be healthy and productive members of society. Of course, this being Halle Berry, the famous Halle Berry, who still looks amazing even in menopause, post-menopause. So, you know, I just like to pay homage to the women of our society. And we all know that women are the pillars of a society as well as a family unit, not taking anything away from men. But I'd also like to thank our RMP in Empath, Dr. Priya Pillai, for her leadership. And I'd like to say that today only, Empath was given a snippet by our Lira Wellbeing Society, which said that women give life color. Research says they provide critical structure and valuable perspective in society. Not only do they take responsibility for their family's well-being, but they guide the family's emotional development, spiritual direction, and mental health. Moreover, studies suggest societies tend to flourish in places where women are valued. Education systems are stronger and economic activity is healthier. Innovation, entrepreneurship, and creativity flourish, and there's better social inclusion. According to these findings, societies tend to prosper more in terms of their political stability. So, not to wax lyrical, but we all know in our homes and in our workplaces, the multidisciplinary, multitasking that a woman can do. And I'd like to thank the many men that do support women at home and the workplace and in our country. With regards to menopause, what is menopause? So menopause is defined as 1 year since the last period. So this diagram on the right is a very nice diagram, and it shows that when a woman has had her final menstruation, she may or may not know that's her last period. But if 1 year has passed since that last period, she is said to have reached menopause. The period prior to that, encompassing at least 2 to 5 years, and sometimes up to 10 to 15 years, depending when she starts experiencing symptoms, is deemed as the perimenopausal period. So of note, it's when the symptomatology of the menopause starts that a woman is said to be in perimenopause. And when we go through this, we'll see that the symptomatology is vast. And the continuum or the spectrum is also a long timeline. If one considers, on average, the continuum starts at age 40 when the estrogen starts to decline. On average, women then reach menopause at age 51 and thereafter still experience symptoms of menopause 5 years on average after. This is a large proportion of a woman's life. Postmenopause is said to be the 1 year period after having reached menopause. So how do we diagnose menopause? Is it based on biochemistry? As much as I'm a laboratorian, I would say no. The diagnosis of perimenopause is based on the onset of menopausal symptoms. So it is when women start to experience this decline in estradiol clinically. And as I said, on average, it starts around age 40 and it reaches, I would say, a peak at age 45, 5 to 6 years before, and then she reaches menopause at age 51. However, as you know, some women go into premature menopause before age 35 and early menopause before age 40. According to the Australasian Menopause Society, I really like the symptom score sheet, and this symptom score sheet is based on the modified green score. This can be completed by the patient themselves in the waiting room or with the doctor in his room. And basically, she gives herself a score for 1 for mild, 0 for no symptoms, 2 for moderate, 3 for severe. And if she tallies up 15 or more, it's significant, it's indicative of estrogen deficiency, warranting her starting HRT. And, women are often, they have a high tolerance level, and most of the time their score would tally up to 20 or 50. And once she goes onto HRT, the score should reduce to 10 or under in 3 to 6 months when you review her after 3 months. And this score sheet is also helpful once you are seeing the woman on HRT to see that the HRT is efficacious. We will come to this later, where you see that even biochemistry may not always be the only tool in judging whether HRT is adequate. It's very much symptomatology based. The symptoms are then divided into 4 categories: vasomotor, which includes hot flushes, headaches or migraines, lightheaded feelings; psychological, which includes anxiety, depression, feelings of being unloved, mood changes, insomnia. The locomotor symptoms include backache, joint pains, muscle pains, and the urogenital symptoms include dyspareunia due to a dry vagina, uncomfortable intercourse, and frequency of micturition. The interesting features would be the dry skin and the crawling feelings under the skin. And one of the guests actually on Oprah's podcast, Naomi Watts, did mention that she went to numerous specialists and none of them ascribed the crawling feelings under her skin to menopause. She had been to many dermatologists. It was HRT that actually ameliorated her symptoms. So on the right here, we have the very varying symptoms of menopause, and the brain fog can be significant. We know of the brain fog in COVID, and then we have the brain fog with menopause. One also remembers that in pregnancy, women also experience brain fog. But the brain fog is due to the neurotransmitter activity of the reproductive hormones. Estrogen, progesterone have all been to have an effect on the serotonin and dopamine levels as well as the neurotransmitter pathways. The difficulty concentrating, the migraines due to the vasodilatory effect of the vasodilatory effect of the low estrogen, dizziness, palpitations, for which many women end up going to the cardiologist and have difficulty clinching a diagnosis, anxiety and depression, night sweats, mood swings, a loss of libido, stress incontinence because the estrogen is responsible for the tautness of the muscles in the urogenital system, the irregular periods. So women still will experience irregular periods in the perimenopausal period. And it's important when a doctor asks if a woman is having all of these symptoms and the doctor says, but did you have your period? When last did you have your period? And they said last month. Oh, you're not in menopause. That's not actually true. The patient is still in the perimenopausal period and she's having irregular periods. It's just up until she has that last period, a year after that, she's cessated. However, she's still in the perimenopausal period having irregular menses. The joint pains, many women present to rheumatologists thinking that they have arthritis. Brittle nails, dry and itchy skin, as we mentioned, mood swings, hair loss for which the differentials are quite varied. So according to the Australasian Menopause Society and British Menopausal Society, they advocate that one should not check the FSH, LH, estradiol, or testosterone in a woman with menopausal symptoms over the age of 45 years old to diagnose menopause. This is because, as mentioned, the diagnosis of perimenopause is based on symptoms and the indication for starting treatment is clinical. And remember, this continuum can start as early as 35, on average at age 40. And we should not deprive our patients if they are complaining of these symptoms, and HRT is likely to benefit them. So the diagnosis is based on the history of menopausal symptoms. And if you do an E2 and FSH in this period, you might find a very high E2 and a normal or low FSH. And one would therefore say the patient is not in menopause. However, during this period of perimenopause, this 10-year on average period prior to reaching menopause, there are these spikes, and these spikes are then followed by dips, and the spikes are responsible for things like the breast tenderness. If you measure, you want to know, is this patient ovulating? What's their reproductive potential? One should do a day 21 progesterone. And then if they are less than 20, they are generally anovulatory around this period. And on the day 21, one can also measure the E2 to progesterone ratio, which is usually in the region of 10:1. However, in this period of perimenopause, there's an estrogen dominance, so that E2 progesterone ratio would generally be higher than 10:1 with the estrogen spikes. And that estrogen dominance is responsible for the PMS, with the progesterone being low in that time period. Inevitably, though, one goes into a state of estrogen depletion with the E2 less than 55 picomoles per liter when they eventually do reach menopause, and when you have your dips. So there's spikes and there's dips in this time period. So what about the entity of premature menopause? Premature menopause it differs. In America, it's defined as menopause before the age of 40. In South Africa and in our lab, we use a cutoff of 35. And here one should this is when less than 45 years, one should measure FSH. And with regards to the entity of premature menopause, less than 35 years of age, one should take a day 2 or day 3 FSH and confirm this 4 to 6 weeks apart. And if the patient has early menopause or premature menopause, premature ovarian failure, or premature ovarian insufficiency, that is menopause less than 35, early menopause is less than 40, one should offer her HRT till the average age of 51. And from my reading, one can also give the patient instead oral contraceptive pill, which has both estrogen component and progesterone component, which then confers the benefit of also being a contraceptive, because these women with their LH at certain cycles being, their LH can still be less than 20 in certain cycles, there are still a possibility of falling pregnant. And hence, one should not look at HRT as a form of contraception. The oral contraceptive studies have shown has also been found to have bone benefits. The only thing is that HRT does confirm a benefit in terms of lesser propensity for hypertension as opposed to the oral contraceptive pill. So once you are on HRT, the symptoms again guides the treatment. Here again, you're not going to go on your FSH and estradiol levels. However, we'll come to that in the next slide. It depends on if they're on bioidentical hormones or non-bioidentical hormones. So on HRT, we'll come to measuring. When you're going to diagnose your patient for HRT, one has to look at the patient's history, obviously, history of any breast cancer in the patient herself, history of venous thromboembolism, liver disease, malabsorption, her preference for a gel versus a patch versus oral. And these are all the things that one has to bear in mind. So it's a very individualized approach. The transdermal route, the transdermal estrogen patch, has been found to be beneficial in patients with a BMI more than 30 or a patient that's at risk of venous thromboembolism, as well as patients that are having gut issues where there's a problem with malabsorption. So the differential diagnosis of menopause, as we mentioned, is wide, including iron deficiency with the hair loss, hypothyroidism with your chills and your hot flashes, depression with the depressive symptoms, treatment for depression with venlafaxine included can cause hot flashes, and uncontrolled diabetes is also a differential as well. So as we mentioned, like with the memes, the women get the night sweats, the drenching night sweats, the hot flashes, the sore tender breasts, the migraines, cognitive and memory problems, dry skin, irritability and mood changes, and weight gain and slowed metabolism, which is not without its cardiovascular risks. So when it comes to the physiological consequences of menopause, the vasomotor symptoms of hot flashes and night sweats is not just a benign entity. It can be a harbinger of something more serious because it's giving you an indication of what's happening at the level of the blood vessels, and therefore these women are at a higher risk of hypertension once reaching menopause. Cardiovascularly, women are at higher risk for cardiovascular events, having a higher total cholesterol, higher triglycerides, higher LDL, higher apolipoprotein B, and as well as increased atherosclerosis in the coronary arteries. The dyslipidemia we mentioned, they also had higher risk of dysglycemia and increased insulin resistance once having reached menopause. And these factors are all ameliorated with the use of HRT. With menopause, you also find the weight gain and increase in the total body fat, as well as central fat accumulation. And studies have shown that the HRT does also help in decreasing the central fat accumulation. Obviously, one has to have a good lifestyle measures implemented as well, with a good exercise regime, healthy eating, and a stress control, as well as good sleeping habits. The other consequences of menopause include a decline in your lean body mass or sarcopenia, and as well as accelerated bone resorption and osteoporosis. Studies have shown that HRT started within 10 years of the onset of menopause or before age 60 has definitely have proven benefits, positive benefits in ameliorating cardiovascular disease as well as osteoporosis. The urogenital atrophy is something women do suffer with dyspareunia as well as a frequency of micturition. And here the local vaginal pessaries are good in the sense that they have a decreased risk of systemic absorption. These women, once reaching menopause, are at risk of depression, as well as we mentioned the low libido. With the depression, the SSRIs are not advocated until one has put the patient on HRT, as it has shown to have a positive cognitive benefit, especially if started within 5 years of reaching menopause. With regards to the low libido, we are very fortunate in South Africa to have Femigel, and this is approved by SAPRA, whereas in overseas countries, especially the US, they had to microdose the male testosterone for women, and just recently it's been promulgated by law. So the concerns of HRT include that of breast cancer, and this was brought to the fore by the Women's Health Initiative in 2002, where it showed that there was a slightly increased risk in women having breast cancer after starting HRT. However, this was a skewed study, and when the data was reviewed and the older women were excluded, they found that there was minimal to no risk for women to use HRT once reaching menopause. The caveat to this is if that the woman has a history of breast cancer herself. And this is when the individualized approach comes in, and the doctor one can still institute HRT for a period of 5 years. And there as well, one can use the microgenized progesterone as an alternative. And there are also natural remedies available like black cohosh, but for the cardiovascular benefits, the estrogen component is very important, and the doctor has to balance this risk with the patient's previous history. Having had a family history of breast cancer does not preclude the use of HRT. And that is because studies have shown that HRT does not initiate breast cancer in the patient itself. It's that if the patient has an estrogen positive tumor or a tumor that responds to estrogen, that this would initiate or exacerbate the tumor. However, it is not the initiating factor. So having had a family history of breast cancer is not an exclusionary factor for starting HRT. With regards to women with a venous thromboembolism, there are options like the transdermal estrogen patch, as well as microgenized progesterone, which both decrease your risk of venous thromboembolism and stroke. In patients with endometrial carcinoma, if a woman has an intact uterus, it's very important to balance the use of the estrogen component of your HRT with progesterone. So that there decreases the risk of endometrial hyperplasia. So in a woman that has been treated for endometrial carcinoma, that is still not an exclusionary factor for using HRT, and the doctor has to carefully measure the pros and cons in these patients. However, it's not an exclusionary factor. So this diagram is, once we come back to this diagram, and it's a very nice diagram, and the large bodies have the International Federation of Gynecology and Obstetrics, that's FIGO, SASOG, which is the South African Society of Obstetricians and Gynecologists, the North American Menopause Society, and the British Menopause Society all concur that women initiating HRT less than 60 years or within 10 years of their final menstrual period show a lower risk of cardiovascular disease and have increased bone health, persisting beyond cessation actually of the HRT. And as we mentioned, the transdermal estrogen is very helpful in those patients where they, for example, are on the GLP-1 agonists, which are now very commonly used, your Ozempic, your liraglutide, which has been approved for weight loss in patients over 30, with the BMI over 30, or patients who have overweight with one risk factor. So if these patients have digestive issues or they have malabsorption, one can then use the transdermal estrogen. One can also obviously use the transdermal estrogen in your patients with a risk of venous thromboembolism. And as mentioned, your microgenized progesterone is also helpful in your patients with a history of breast cancer. And it also does not confer a risk in patients with venous thromboembolism. Testosterone is used in the climacteric to increase the libido if the HRT is not doing their job. And here, this diagram is showing the testosterone is the last hormone to go. The very first hormone to deplete is actually progesterone. And this is responsible for your insomnia and your anxiety. And hence, this component is also important, especially in a woman with an intact uterus, as mentioned. Eventually, a woman has androgen dominance, but this diagram is not fully representative because actually the testosterone is lower at the end than when it started because of a decline in production from the ovaries. And because of this, the woman has the low libido. And as mentioned, we have testosterone gels in South Africa that work very well if used in the correct quantities on the inner arms and inner thighs, and as prescribed by the doctor. And, the one indication is that one should measure your free androgen index once the patients are on this gel to ensure that they are not over supplementing themselves and experiencing the androgenizing effects of too much of testosterone. So pre-testosterone is the hormone that is best to measure. However, a free androgen index using testosterone SHB and the calculated free androgen index is a good surrogate marker, especially if checking for excess. I'm proud to announce that next year we're going to be looking at rolling out the free testosterone assay on the LCMS platform, which is better in women who are on the lower end of the spectrum to check for women that are deficient in the androgen, the free androgen, the actual testosterone due to menopause. As mentioned, the vaginal estrogen is useful for the urogenital atrophy, and that's the pessaries and that's good localized use. And the use of HRT previously was thought to be for 5 years. However, the guidelines now state that there's no specific cutoff, that women can use it safely for as much as 10 years up until 60, and safely with annual monitoring. One should monitor 3 months after initiation and thereafter annually. In the menopausal time period, lifestyle measures of portion control and diet with correct caloric intake, aerobic and resistance exercise, good sleep, stress reduction using meditation techniques, etc., are also very important. And with regards to the biochemistry perspective, I am a laboratorian. To summarize, FSH and E2 should be used as markers to see if the patient reached menopause. If the patient is less than 45 years old, because generally if they are older, they are in that perimenopausal period with their spikes and their lows, and it's very difficult to definitively diagnose that this patient is in menopause. One goes on symptomatology. The bioavailable hormones are now amazing, and women are finding them to be very much more like they are hormones themselves. These are enantiomers or mirror images of our physiological hormones. They are also called body identical estradiol, and they actually they are sourced from wild yam, and they are refined in the lab to form a molecule called diosgenin. So it's just not taking wild yam. You'll never get the same effect. It has to be in a pharmacological preparation. And so these bioavailable hormones are picked up in our assays in the lab. So we'll find an increase in your E2 in your patient and a decrease in your FSH. And you can see if your patient's responding. However, the E2 may be low if the HRT is not picked up in our assay. Example, use of the selective estrogen receptor modulator tibolone that works on the estrogen receptor, or the conjugated equine estrogen, example, Premarin, which is made from the urine of a mare or extracted from the urine of a horse. So these are not picked up in estradiol assay, and so it's very difficult for you to judge whether your patient is sufficient or not if they are on these older, non-identical HRT preparations. If the patient has recently ceased HRT for whatever reason, you might find that her E2 is still low, but her FSH has not yet increased because it's still a very short period since she stopped. And if your FSH is in the low area, but this is an older patient in that menopausal age group, one should consider the entity of pituitary insufficiency and do a full pituitary profile with your ACTH, your prolactin, your growth hormone, and your cortisol and your TSH, etc., to ensure there's no pituitary insufficiency. So when do we check these patients' estradiol on the HRT? As we mentioned, there are spikes and E2 fluctuates in this perimenopausal period and even on the HRT. So here we say dose the HRT according to symptomatology and how is the patient feeling. The only times one should really measure the estradiol is, are the symptoms not improving? Is there some element of malabsorption at the level of the gut or at the level of the skin if she's using a gel or a patch? Also, if it was a younger symptomless woman to begin with, where she didn't have symptoms and one started her on HRT, and now it's difficult to ascertain whether the HRT is working or not, one can look at the estradiol. And studies have shown that the bone benefits or the osteoporosis benefits are conferred when the estradiol is greater than 200 picomoles per liter. One should check estradiol if the patient is on a patch, gel, implant, or spray, and to look at how much is being absorbed. Avoid taking the blood from the hand with the patch or that the gel has been applied on or applied with. And take the estradiol just before the patch is changed to a new patch. So just when you're removing the old patch. Levels should be around 180 to 370 picomoles per liter. And it should not exceed 800 picomoles per liter because one has a risk of endometrial hyperplasia, which is a risk for endometrial carcinoma. So in conclusion, regarding the menopausal aspect of my talk, I'd like to say one should individualize treatment, help women make informed decisions about menopause management. Do not use blood tests to diagnose perimenopause or menopause in a woman over age 45. It's based more on symptoms. Offer HRT first line for any menopause-related vasomotor symptoms and low mood. Previously, SSRIs were used as well as things like Dixerit. However, studies have shown that HRT has a marked benefit on cognition as well as depressive symptoms. So the other drug used to be clonidine. Do not routinely offer clonidine or antidepressants. Do not use fluoxetine or paroxetine in women using tamoxifen as their drug interactions. Tamoxifen obviously for women who have had breast cancer. Offer long-term vaginal estrogen for women with urogenital symptoms. Even if they're taking HRT, the absorption is very low systemically. Understand appropriate review and when to refer to a gynecologist who has experience in the field of HRT. Support women to choose when to stop HRT and do not choose ARB limits of, for example, 5 years as in the past. Use pictorial charts to discuss the risks and benefits of HRT. And you can use blood tests to confirm the diagnosis of premature ovarian insufficiency and offer treatment up to the average age of menopause at least, which is 51. Okay, I'd like now to go on to the next aspect of my talk, which is the polycystic ovarian syndrome. And I'd like to start with a case study about my good friend, the Wonder Woman, who was a 29-year-old Caucasian female in our postgraduate medical training who was married to a healthy male partner. However, she was unable to get pregnant after 1 year of trying. She had a normal physical exam, a healthy BMI, no alcohol or drug use, and she did describe irregular and painful periods post-menarche, which she reached at age 13, for which oral contraceptives were prescribed. So the differentials here would be things like endometriosis, polycystic ovarian syndrome as well. So what is polycystic ovarian syndrome? It's a complex endocrine mediating disorder affecting women, and it's a very common cause of female infertility. The estimates for prevalence vary, and it affects up to 5 million of US women of reproductive age, costing the US healthcare system in 2005 around $4.5 billion US dollars. Many affected women remain undiagnosed, and the criteria for diagnosis remains controversial. So, as mentioned, 8 to 13% of women of reproductive age worldwide are affected by PCOS. 50% of these women suffer from infertility. 50% of women will develop type 2 diabetes or pre-diabetes by age 40. And 66% of women affected by PCOS remain undiagnosed. This is actually Roche data. The previous data was from the International Consensus Review Statement for PCOS. So as can be seen, the effects of PCOS are far-reaching, including, once again, psychosexual dysfunction due to body habitus or body changes, depression and anxiety, obesity, cardiovascular risk, pre-diabetes and diabetes, hyperandrogenism, infertility, ovarian cysts, acne, and irregular cycles. So, with regards to the biochemistry or the pathophysiology of PCOS, the exact cause is actually still poorly misunderstood. But what we think is that at the level of the hypothalamus, there's an increase in the GnRH pulsatility. And these increased pulses lead to an increase in LH secretion, which eventually leads to an increase in your androgen production from your ovary as well as your adrenal gland. Here in your ovary, you can see there's an increased testosterone, an increase in androstenedione, which gets peripherally converted to estrogen, and then by the enzyme 17-beta-hydroxysteroid dehydrogenase and 5-alpha reductase to dihydrotestosterone, which is the most potent form of testosterone and causes things like male pattern baldness. So in net effect is that you have an increase in your androgens, you have an increase in insulin resistance, and you have because of a decreased SHBG, you have an increase in your bioavailable testosterone. So more bioavailable testosterone floating around. And there's also increased conversion of the androstenedione to estradiol in the adipose tissue and dihydrotestosterone by 5-alpha reductase. So with regards to the phenotypic manifestations in the patient has long-term effects of PCOS, and this extends to both metabolic and reproductive risks. They have clinical hyperandrogenic symptoms, including hirsutism, acne, seborrhea, alopecia. They are at risk of type 2 diabetes, insulin resistance, cardiovascular disease, infertility, menstrual dysfunction, endometrial cancer due to hyperplasia. And sadly, this is from a German study, and the dark red shows the PCOS patients have a decreased physical functioning, decreased general health score, decreased vitality score, and socially they are as well inhibited. Their mental health suffers. So women with PCOS are on average 3 times more worried about their fertility than women with normal androgen levels, and they experience a 50% reduction on average in their quality of life, which is very sad. As mentioned, the signs and symptoms of PCOS include go across all spectrum, all systems, including psychological, where patients may have a negative body image, have eating disorders, anxiety and depression. Reproductive, as we mentioned, irregular menstruation. Generally, these patients have less than 8 periods a year. Even if they do fall pregnant after being infertile, they may have pregnancy complications. Dermatological manifestations include acne, alopecia, acanthosis nigricans, and hirsutism. And metabolic complications, as mentioned, are far-reaching due to the hyperinsulinemia. So when it comes to the criteria for PCOS diagnosis, one has to rule out disorders that mimic the clinical features of PCOS, including hypothyroidism and congenital adrenal hyperplasia. And we still follow the 2023 guidelines, international guidelines, models the 2003 Rotterdam criteria, which say that 2 out of the 3 criteria has to be present to diagnose PCOS, which is androgen excess, either clinically or biochemically, ovarian dysfunction, which is your anovulation, which is less than 8 cycles a year or more than 35 days apart, your cycles being more than 35 days apart. And the third feature is polycystic ovarian morphology, either on ultrasound and now on a blood test. So you can measure a hormone to assess polycystic ovarian morphology. So when it comes to biochemical hyperandrogenism, how do we know that these patients have excess androgens? We have to measure the free component and the total component. And the total testosterone and the free testosterone are measured. And a surrogate marker of this is the free androgen index, which gives you a marker or a surrogate for the bioavailable testosterone, which is wreaking the havoc. This is on the upper end of the spectrum, or the hyperandrogenic patients. This assay is acceptable. For the lower end of the spectrum, one should use the LCMS measurement, which, as I mentioned, is coming out next year with AMPATH. And one should remember that hormonal contraception affects SHBG. So if you are measuring your androgens in these patients and you want a good reflection, one should cease this for 3 months before measuring to get an accurate reflection. And markedly high levels of the total testosterone itself, not the free testosterone per se, may suggest an androgen-secreting tumor. Hence, we need the total testosterone, the SHBG, and the free testosterone, which is the bioavailable component. The androstenedione and the DHEAS gives you limited additional information. The DHEAS made by your adrenals, and the androstenedione is helpful in your PCOS patients, though. Clinically, one uses scores like the Ferriman-Galway score for the hirsutism, and one can assess for terminal hair in the male-like pattern on the face and the terminal hair, as well as in the pubic area. And this is along the linea alba. And then androgenic alopecia, we use the Ludwig visual score to measure for hair loss. With acne, there's no visual assessment that's universally accepted. So one should definitely confirm a diagnosis of PCOS. Ask the medical history. Are the periods, less than 21 days apart? So is she actually having periods more excessively? Is she oligomenoric, where it's more than 35 days apart? Does she have prolonged or heavy menstrual bleeding? Does she have does she self-care? Does she wax or shave? Because this actually may throw you off and not give you a true reflection of the hirsutism that she's experiencing. Assess for the presence of skin symptoms like acne, hirsutism, seborrhea, and alopecia. Measure the biochemical evidence of elevated androgens. The physical exam, one should look at the BMI, the waist-height ratio, the blood pressure, and consider the psychosocial impact of this disorder and the long-term health risks. So the tests that one should know to do is to consider doing an ultrasound, obviously to look at the polycystic ovarian morphology on ultrasound. However, one has to have a transducer that's more than 8 millihertz, and one has to be experienced in measuring for the ovarian volume as well as the number of follicles per ovary. 17-OHP to exclude CAH, 24-hour urinary free cortisol to exclude Cushing's, DHEAS to exclude an androgenizing tumor, and your anti-Mullerian hormone, which we'll come to next. So in summary, I would suggest in a query PCOS patient to look at doing your FSH-LH, to look at your LH-FSH ratio. Is it greater than 2:1, which you'll often find in these patients with a low E2, your androgen profile, your TFT, your prolactin. Your prolactin you'd often find in these patients a little bit on the higher side. Your 2-hour GTT to exclude a diabetic state or a pre-diabetic state. fasting insulin, fasting lipogram, DHEAS, 17-OHP, cortisol, and anti-Müllerian hormone. I'd like to spend a little bit of time on the marker of anti-Müllerian hormone. This is a novel marker now for diagnosing PCOS as of 2023, where it is difficult to sometimes look at that pearl on a necklace appearance on the ultrasound. Anti-Müllerian hormone has been used for many years in assisted reproductive clinics to look at the patient's ovarian potential and the ovarian reserve, to look at these patients, are they at risk of ascites and ovarian hyperstimulation syndrome, which has a high morbidity and mortality. But it's also been found, besides having the IVF use, to also be generally higher, the AMH value, in women with PCOS because of the number of follicles than in normal ovulatory women. So in AMPATH, we have our various ranges for IVF, which will show if you are responding to ovarian stimulation and the number of oocytes that one would get at retrieval. But more importantly, we now have for PCOS diagnosis a cutoff on our Roche platform for women aged 25 to 45 years of age with a very good sensitivity and specificity, above which one would fall into the PCOM, polycystic ovarian morphology category, will fulfill that category for PCOS diagnosis instead of your ultrasound. So if they have 2 out of the 3 features, they are considered to have PCOS. So as mentioned, there are many clinical manifestations associated with PCOS, including Pickwickian syndrome or obstructive sleep apnea. They had increased risk for cardiovascular disease. And the lifestyle interventions for these patients obviously include a healthy lifestyle, a healthy diet, regular aerobic and resistance exercises to maintain a healthy weight, and behavioral strategies. The hormonal contraceptives for the hyperandrogenism aspect would include things like your diane or cyproterone acetate, your metformin for your weight management and metabolic disorders. For your patients who are trying to fall pregnant, your Clomid or your letrozole, for patients that are experiencing their anovulatory cycles. And then once again, your anti-androgenic medications like cyproterone acetate for the hirsutism and alopecia. Surgical options are reserved for the very serious cases and include things like ovarian wedge resection or oophorectomy if the patient has completed their family, and or ovarian drilling. So the AMH hormone has been found to, be a very amazing assay because it shows you the patient's ovarian reserve and their response. Once they get into this program, their response to the controlled ovarian stimulation with the FSH injections. With regards to infants, the role of AMH, as you know, is that it causes regression of the Müllerian ducts in the male hormone. In its absence, the Müllerian ducts develop into female reproductive organs. So the other use of this assay is to assess whether the patient has anocordism or a lack of testes as opposed to cryptocordism or undescended testes. And as we mentioned, it's used as for the PCOM as a aid to PCOS diagnosis according to the 2023 guidelines. Once the patient is in a program for IVF, the doctor uses the AMH to dose the patient with folitropin delta. One can also use AMH in patients that have ovarian granulosa cell tumors as a tumor marker. But the main modalities of AMH is that it tells you the true ovarian reserve in these patients as it correlates with the number of ovarian follicles or antral follicular count. It's a marker for prediction of hyperresponse or as well as these patients developing hyperstimulation syndrome, and it's used for dosing of recombinant FSH in IVF. Thank you. I think